Welcome again, Faves number 16. We're super excited today to have two people that I would say are new to our Phage community, and we recently got to meet them through kind of email, other Faves events, but so their names are Greg Canfield and Laura Damioli, and we were chatting about how they recently treated their first patient with phage therapy in Colorado. And so they're going to talk about that experience. It's going to be a joint talk. And so excited because, yeah, they've managed to treat this spinal hardware infection with phage therapy. And this is all part of a series that we're doing through PHAVES that's focused on clinical use of phages. So if people haven't noticed that, we're starting to do kind of alternate clinical versus like more phage research with these PHAVES. So next week, we'll be back to the research side, but this is our clinical version for the month of May. So thank you for coming, and yeah, ask questions as many as you want. So with that, I'm going to hand it over to, I don't know who's going to start, Greg or Laura, but you can feel free to give an intro of yourselves and then head into your chat.
Awesome. So thank you guys so much for having me here. I'm Laura Damioli. I'm the Director of Orthopedic Infectious Disease at the University of Colorado. I did most of my training down in Louisiana at LSU for my fellowship in infectious disease, my residency in internal medicine at the Ochsner Clinic Foundation, and went to medical school at Mercer University in Georgia. I've had the honor of having Greg Canfield as one of my fellows over the last few years, although we're going to lose him here soon when he goes off to do an ICU fellowship. And I'll let Greg talk for himself, but he's an MD, PhD, and has been working in Breck Dirkop's lab for the past year. And together we treated our first patient with bacteriophage therapy over this past year and have had what I think is a pretty great result. And the patient and her family are on the line right now. So if she has anything to add to the chat or questions or anything, they're wonderful people, and I'm sure would be happy to be part of this. So our talk is Freedom from Antibiotic Purgatory, Salvage Phage Therapy for Cure of Spinal Hardware Infection. And this is a picture of our campus at University of Colorado. Now I'm controlling Greg's computer, so let me make sure that if I hit an arrow, I don't think anything happens. Where did it go? Greg, what's wrong with it?
Oh, you just had it, Lou.
Oh, there it went. Okay. Okie doke. So to start with, and I'm going to take the video off of me because otherwise I have issues because I have to talk into my phone and then use the computer. Sorry, guys. So to start with our patient case. She came in with a chief complaint of wound dehiscence. And it's an 80-year-old Caucasian female who came in back on June 30th of 2020 for a T3 to ilium posterior spinal fusion. She has a past medical history of kyphoscoliosis. Still struggling with the computer here. Neurogenic bladder, status post a catheter. So she has a suprapubic catheter in place. And recurrent UTIs. These have been in the past year. She'd had 4 of them treated. Others had been culture positive bacteriurias, but without evidence of infection on the UA. You can see here that she has persistent colonization with Pseudomonas, but also grows out other organisms such as E. coli and E. faecalis. She also has a history of a brain aneurysm, and that has been coiled. And a history of rheumatoid arthritis on a JAK inhibitor, Xeljanz. History of a transient ischemic attack, and a history of collagenous or microscopic colitis, for which she's occasionally on oral budesonide. She initially came and saw me prior to her spinal fusion. Given her history of recurrent UTIs, there was concern that she would seed the hardware when it was placed and end up with an infection. And I advised her that she was at high risk for this to happen, that attempting to eradicate chronic urinary colonization doesn't have great outcomes, but we could certainly try. So I put her on Zosyn for 5 days pre-op and continued at 5 days post-op IV. And while I knew that we wouldn't get great dwell times due to her suprapubic catheter, I was kind of pulling at straws and put her on methenamine as well in an attempt to try to sterilize the urine. On the day of surgery, the week before surgery, the 625 urine culture is what she grew prior, and how I chose the piperacillin tazobactam or Zosyn to try and treat all of her organisms. And on the day of surgery, 629, there was a repeat culture that didn't have anything significant in it, but did still show evidence of urinary colonization. So the surgery went forward on 6/30. It was uncomplicated. No cultures at that time turned positive, and she was discharged on 7/22 with a wound vac. This is just a picture of what her spine looked like. You can see the extent of how much hardware we're talking about. And I think in the picture on the right, you can see that even after all of this fixation, she still has a significant degree of scoliosis. So obviously, if all of this hardware becomes infected, we're going to have a problem on our hands. And that's what happened. On 7/27, I got notification from her orthopedic spine center that her wound had dehisced, and that this picture is what they were seeing. It was cultured and grew Pseudomonas. And it grew 3 different, and this is a superficial culture, we'll get into why in a second, but it grew 3 different colony types of Pseudomonas aeruginosa. They all had the same sensitivity pattern, but they did look different on the auger plate. So at that point, I told the ortho clinic to start her on Levaquin and get her in to see me as soon as possible. And she came to see me a few days later, and I put her back on Zosyn, and I spoke to her surgeons about her needing a washout. But they were worried about her frailty and that her poor soft tissue envelope, and they were hoping that we could make progress with a wound vac and antibiotics and then maybe wash her out down the line. And I said that I would be okay with that if there's no evidence of deep, like, infection with complete lack of source control and an abscess where I thought we would just drive resistance. So we got imaging that did show a small focus of gas posterior to the spinal canal at the L3-4 disc space. And then over that weekend, her wound was not making any progress with the wound vac and the Zosyn. And so she came into the hospital. That's the gas right there. So she came into the hospital for repeat washout on August 4th. Her spine cultures grew the same pan-sensitive Pseudomonas aeruginosa that were cultured from the superficial site. And then on 8/6, she underwent a muscle flap. So typically in these cases, we would do repeat debridements until culture negative and then do a flap. But with her other medical comorbidities, deconditioning, and frailty overall, the surgeons were hesitant to do that. And by this point, we'd already kind of been talking about phage, so they were a little bit hopeful that maybe we had something else to offer. So they went ahead and flapped her after 1 debridement. And on 8/13, she went to a skilled nursing facility. Her postoperative course was complicated by orthostatic hypotension, symptomatic anemia, and poor wound healing. And here you're going to see the pictures. So this is 8/3 is the day that she went in for the flap. You can see the wounds even worse in the picture I showed you prior. And then this is post-op when the drains are in place. Then this is about 6 weeks into IV antibiotics from the time of debridement. And you can see where these arrows are pointing to. We still appear to have fistulous tracts. Her surgeons were hopeful that these were seromas and didn't go deep to the hardware, but that unfortunately was not the case. And this is even later showing that she still had a persistent fistulous tract that on review of imaging went straight to the hardware. So this is the imaging that we have from July compared to September. And you can see where the top arrow is on the right. It's a very large air collection, gas collection. And on different image views of the CAT scan, you can see that it tracks straight to the hardware. So the bane of my existence and basically what I do for a living is hardware associated infections. And the reason they're so difficult to treat, as all of you know, is because of the biofilms. And without sterilization of the hardware, we expect the infection to come back. Although how long you have to treat to make that risk go away, no one really knows. And antibiotics basically can't sterilize the hardware unless the hardware gets removed and new hardware gets placed. And with the extent of her fusion, that really wasn't an option in this case. So these situations typically in my practice, and I think around the world, are dealt with, you give an IV course up front or maybe even orals, and then you give chronic suppressive oral antibiotics. The problem in this case, and that's how you end up in antibiotic purgatory, where you're just stuck for forever, basically with nowhere to go. The problem in this case is that fluoroquinolones are the only oral agent available that have activity against Pseudomonas aeruginosa. And your options here would be Levaquin and ciprofloxacin. But our patient was a very poor candidate for using a quinolone suppression long-term. And so this is the black box warning from the FDA saying that fluoroquinolone should not be used in patients unless there's no other options available, especially if they have a history of aneurysms of the aorta or other blood vessels, or if they're elderly, have other high blood pressure, certain genetic disorders. And we'll get into more of that. I lost my little thing here. Where did it go? there we go. So more on fluoroquinolones is that if you look at the cumulative incidence of aortic aneurysm or dissection, comparing fluoroquinolones to amoxicillin, we typically get taught that the risk goes up after 30 days. That's what I usually preach to patients. But if you look at this graph here from Pasternak in the British Medical Journal, it looks like even within the first week, we start to see an increased risk of aneurysm or dissection with the use of fluoroquinolones. This is, and we think that it's due to the production of MMP2 in the tissues, which is causing a destruction of the collagen or a displacement of the collagen and loss of the normal connective tissue design. So one of the studies that was put out recently, and actually I think I saw Gina Suz on the call, this is one of her papers, but is that, how do patients in general tolerate quinolones? And the answer is not very well. They found that in patients treated with rifamycin and a quinolone for a prosthetic joint infection, that 36% of the patients in the fluoroquinolone group had to discontinue their drug due to side effects, whereas it was only 3% in the non-fluoroquinolone group. And a lot of times this was due to severe adverse events. They had a lot of different adverse events that were reported in their table. I think it's table 4. They talk about how some of the patients ended up with aortic aneurysm, dissection, acute hepatitis, C. diff, or retinal detachment. And once again, this is significantly more common in the fluoroquinolone group compared to the non-fluoroquinolone group. And then looking at time to antibiotic discontinuation, just for simplification and to not make the talk go for hours, we looked just at the hip data, and you're looking at 9.5 weeks compared to 20.3 weeks. And then if you look at all overall adverse effects, much higher risk of adverse effects with tendinopathy, myalgias, arthralgias, diarrhea, rash, itch, encephalopathy in the fluoroquinolone group compared to not. So in general, these aren't well tolerated. And so talking to my patient about you're going to go on this drug for the rest of your life, or at least a year, seems pretty scary, especially with her history of cerebral aneurysms. And just to kind of, when we presented this to our own department, there was a question of, how big is the risk of quinolones? That's why this topic has a lot. But for the people on the call that may not be clinicians, one of the bigger risks is QTC prolongation. That time in between heartbeats can be prolonged. And obviously, if it prolongs too much, you die. So the mechanism by which this happens is you go into torsades, which is a form of VTAC, and is a non-survivable or not compatible with life rhythm. You can also get dysglycemia, hypoglycemia, encephalopathy, and peripheral neuropathy, C. diff, colitis, which our patient already had a history of, and drug-drug interactions, especially if the patient's on warfarin. So with all of these things being considered, I offered the patient 3 different options. The first was IV antibiotics, and typically we would give a patient 6 weeks of IV antibiotics followed by orals. But since the orals didn't seem like a great option, I said, what if we did 6 to 12 months, hope the spine fuses, and then maybe you can go back and have this hardware taken out, or we just stop and see what happens. And if we took the hardware out, we give you another 6 weeks at the end. Option number 2 was to give her the antibiotics and start pursuing bacteriophage therapy, which around this time I was Googling what is a bacteriophage. So that's how where I started with this. And the third option was to just kind of stop and go to hospice and let this take its course, or to give her 6 weeks and then go to hospice. And the patient elected option number 2. So in July, I reached out to Gina Suh up at Mayo to say, hey, what is all this bacteriophage stuff and how do I get involved in it? And luckily I was working with Greg Canfield, who was working in Breck Durkop's lab at University of Colorado. And so he really helped me out tremendously with getting started on this. We were immediately put in contact with Ben Chan, John Koff from Paul Turner's lab at Yale. And we also set up a meeting with the FDA to just find out how does one even get an IND for something like this, because we were really starting from scratch. At the beginning of August, we sent the Pseudomonas strains to Yale, started to draft a treatment protocol, and we heard back from Yale about 9 days later that they found multiple lytic phages, which wasn't surprising because this was a pan-sensitive strain, but they had a lot of options there. And what was interesting was that while the 3 Pseudomonas strains looked the same clinically, they actually had different phage sensitivity profiles and infectivity. So there was a difference between those strains. We submitted to the FDA at the beginning of October and got our endotoxin results back a little bit later, which we then added to the FDA and went through the treatment protocol. And we were granted our IND in December. And this took a long time, I think, mainly because I was new to it and didn't really know what I had to do to get going. Around that time, as you may have remembered, COVID was really rearing its ugly head again, and the vaccines were starting to roll out. And so as a result, the patient was also looking at the upcoming holidays and needing to come to our clinic every day to get the infusion. So she actually requested that, why don't we just wait until, let's set like the first week of January as our start date, and then we'll go then. So that was the plan that we moved forward with. And this is where I'm going to pass it off to Greg to get into some of the more details about the phages.
Well, thanks, Laura. Hopefully people can hear me okay. Let me see if well, say something if you can't hear me. I'm Greg Canfield, one of the ID fellows. I'm a third year here. Just give you my background. So I did my medical school at the University of Buffalo. I'm a native of the area around Niagara Falls, New York. Moved to San Diego. I was at Scripps Green Hospital in 2014, 2016. That was the time Tom Patterson was treated at UCSD with bacteriophage therapy, and we caught wind of that over at our facility. I thought that was pretty cool. So I had an interest in this going into fellowship, and then moved on to fellowship at University of Colorado, and I've been here for 3 years. So I have to say that, the credit goes to Laura for even considering this possibility. You actually have to think about it. And, it took a lot of tenacity to finish this case off and get the phage therapy to the patient, never having done it here. And so Laura's been quite a pioneer, I think, at the University of Colorado. And this won't be our last patient. And maybe she'll talk more about what's ahead in the future as we get through the case. But anyways, so we contacted Ben Chan, Paul Turner, John Koff at Yale, and they were very helpful. They were able to find phages for treating this particular strain of Pseudomonas that the patient had. And Ben sent me their protocol and how they go about evaluating phages. And so basically they use a qualitative method with phage spotting first, more quantitative method once they've identified phages that they're interested in. And that's essentially an efficiency of plaquing versus the Pseudomonas aeruginosa PA01, which is a frequent laboratory strain that's used. And if the efficiency of plaquing was greater than 1, it was considered a strong phenotype. They also evaluate phage killing kinetics, either phages singly or in combination against our strain of interest to see how well it killed. And this was done in like a growth curve or growth curve monitoring machine, plate shaker. And then the phages were assessed for the bacteria were assessed for phage resistance in vitro. And so what they would do was select for phage resistance by plating the bacteria from an overnight culture onto phage containing media, and then selecting some of those colonies and assessing if other phages that were candidates for treatment would be able to still infect those phage resistant colonies. And so essentially they were assessing for cross resistance. So in other words, if resistance to phage A occurs, does the strain remain susceptible to phage B or C? And then they also had mutants in the PA01 background in the outer membrane efflux pumps. And let me just fix my screen here. An LPS motif that, I guess it's not gonna let me, that's fine. That were also assessed. Basically what they found is that these phages seem to infect through what they think are receptors outside the outer membrane efflux pumps and LPS, but that's still being assessed at the moment. We don't really have a good answer to that question today for you. Let's see if I can move forward here. Oh, there we go. Sorry about that. So this is the panel of Pseudomonas phages that were screened against, and they're kind of, well, they're all double-stranded DNA phages of the order Collaborators. And typical is what I've seen, they're either Myoviridae, Cyphoviridae, or Podoviridae. I just have the morphologies here. So all these phages were screened by Ben. And so what they did first, as I mentioned, is they do a spotting assay. And how they interpreted their spotting assay was basically, if you could see plaques up to the 10 to the -6 dilution, that was considered a strong phenotype. You saw plaques between the 10 to the -4 to the -5, that was considered a moderate infection phenotype, whereas plaques or halos seen below 10 to the -4th dilution were considered a low infectivity phenotype. And here's just some examples that I have from my own work that represent the point. So this is phage 1, as you can see at the top of this agar plate, and there's a lawn of bacteria on this plate, and increasing dilutions are going across this plate. And as you can see, this phage, whatever it was, didn't even infect at a very high titer of bacteria, or excuse me, of phage. When you move on to another phage, you can see that you can start to see plaques at much higher dilutions here, suggesting a higher infectivity phenotype or a stronger infection phenotype. And same thing with this third phage here. So that's how they would screen these, and then they would move on to do efficiency of plating to further characterize and make sure that everything was consistent. They would also do, as I mentioned, some resistance testing. So they would, what I'm showing you here on the left panel here is just some phage resistant streaks or colonies that were picked and then streaked on an agar plate. And then what they did was something called a cross streak, where basically you take a drop of bacteria and let it run down the surface of the plate, and you cross streak against it with your bacteriophage of interest. And if a colony is resistant, you won't see basically an area of clearing where there's the phage cross streak. So this would be a resistant colony. This would be a resistant colony. But these two strains right here would both be still sensitive. This one more so potentially. So that's the whole idea of, and the way they tested for cross resistance to phage. And then I just wanted to show you this pretty cool looking picture, I thought, and some of the phage resistant colonies that they had generated to our strain. And so you can see the pyocyanin production on the left here, one of phage resistant colonies to 1%. And I don't know what phages these are. I'd have to ask Ben, but basically you still see this pyocyanin production, colonies of different morphotypes, some bigger, smaller than others, maybe some flatter, some not so flat, kind of just an entire mix. But for this particular, whatever phage this was, phage resistant colonies seem to lack that blue-green characteristic appearance that you see in Pseudomonas. They look kind of almost brown. And what Ben tells me is these are lacking in pyocyanin production, also siderophores. Now we assess that, I'm not exactly sure, but that's kind of the work right now, is trying to characterize these particular bacteria in phage-resistant Pseudomonas strains. I should say this is in difference to what Ben had published on previously in a scientific reports paper, where he used this phage OMK01 to kill a patient's Pseudomonas aeruginosa strain that had gotten on his aortic graft. And so this was our approach to treating our patient. So our patient had an IV access. She had a suprapubic catheter, and she also had a spinal drain in place. And the spinal drain was placed at the actual site where the fistula was forming on some of the prior pictures. And what we had chosen to do was infuse daily with either 5 × 10 to the 9th, 5 × 10 to the 10th, or 1 × 10 to the 9th phage in different amounts of volume here. For the suprapubic catheter treatment, we started with however long the patient can tolerate it. So the phage was infused up the suprapubic catheter and then clamped. And the patient seemed to tolerate this quite well in our experiences. Commonly, her IV infusion would last a matter of minutes. And she would sit there and wait for at least an hour before we opened up her suprapubic catheter again. Additionally, you would think that maybe it would be traumatic to infuse phage into a spinal drain, but throughout the entire course of her treatment, she really didn't have any discomfort associated with infusion of phage into her spinal drain. And overall, she seemed like she tolerated things quite well. So after the patient received her phage treatment for the day, she would 2 hours later receive cefepime, and then we would swap out with a new phage or phages every 2 weeks. And this would go on for an entire duration of 8 weeks. The reason we wanted to go with phage first and then cefepime is that prior work from an in vitro study had demonstrated that it seemed that the order mattered, being that if you infected with phage first or infused with or treated with phage first, followed by antibiotic, that seemed to deliver a better killing effect upon the bacteria. And so this is how we decided to do things. How did we monitor for efficacy? Every 2 weeks, we did a physical exam. So the patient received her infusions Monday through Friday in the infectious disease clinic at CU Anschutz. Whenever she was starting a new phage or phage therapy, every 2 weeks, we would sit there and watch her for the first hour to monitor for signs of allergic reaction or anaphylaxis, of which never occurred. But we got to know the patient quite well during these times, and it was good for that, for sure. We also monitored inflammatory markers, C-reactive protein and ESR, the complete blood cell count, and comprehensive metabolic panel, basically your kidney function and liver enzymes. And then we wanted to repeat a CT scan of the thoracic, lumbar, and sacral spine at 4 weeks to assess how the infection had, whether it responded or not to our phage treatment plus antibiotics. And so these were the phages that we used. And weeks 1 through 2, we used phage INF, which was a myoviridae, whereas I believe the rest of these, a majority of them were cycloviridae. So we used only one phage in weeks 1 and 2. Weeks 3 and 4, we used 2 phages. Weeks 5 and 6, we used another 2 phages. And then weeks 7 and 8, we went back to a 3-phage cocktail, which is essentially a combination between weeks 1 through 4 phages. And this was the whole rationale, as published previously by Ben and Paul Turner. And basically, whenever there's a trade-off, a fitness trade-off that occurs between bacteria that are antibiotic resistant when they have to become phage resistant. And so what this panel is showing you is that phage that are phage OMK01 sensitive, and I should add that OMK01 binds to an outer membrane protein that's involved in efflux, this MEX-AB, MEX-XY efflux pumps. And so when phage OMK01 infects, it'll either kill these strains, or in bacteria that become resistant by mutation of these outer membrane proteins, they'll develop antibiotic resistance. And that's shown here by the change in the MIC. There's roughly a 10-fold reduction in the MIC to ciprofloxacin, whereas there's roughly a half-fold reduction to ceftazidime due to resistance to phage OMK01 in this Pseudomonas strain. Whenever you this was a panel, this panel down here is to assess the impact on biofilm formation and Dacron grafts. So what Ben did is culture bacteria or Pseudomonas, I should say, on Dacron grafts for 72 hours, either in the presence of phage OMK01 plus ceftazidime, ciprofloxacin, or by itself. So OMK01 by itself is the dark bars. Is the dark bars with ceftazidime, ciprofloxacin. And what you can see is that with phage OMK01, it actually reduces biofilm quite well just by itself. And it seems to keep that phenotype as measured here by the OD600 cell density in the presence of both ceftazidime and ciprofloxacin. Interestingly, when you add ciprofloxacin, it actually seems to form more biofilm on the surface of the Dacron graft, whereas ceftazidime seems to have a biofilm lowering effect in isolation away from phage OMK01. And this is just another panel just describing the same thing. Whenever you dilute out phage OMK01, it still has high potency for reduction of biofilm on the surface of Dacron grafts. And this is just, you know, down here is dilutions or multiplicity of infection of phage OMK01 against Pseudomonas aeruginosa. And it was potent up to about the -5 dilution shown here. Okay. So the phage manufacturing process, this is, I guess, what I would consider standard, but bacteriophages were amplified in the Pseudomonas aeruginosa strain called 27853, which is an American type culture collection strain. And this was done in tryptic soy broth. 27853 is a quality control strain used by the CLSI, the Clinical Laboratory and Standards Institute, that comes up with MIC breakpoints in the United States. And so that's, I think, why it was chosen. I don't have any other rationale other than that. So bacteria are grown to stationary phase from an overnight culture. They're subcultured and grown to an OD 600 of 0.1 to 0.6, where at that point, phage are infected in a multiplicity of infection of 0.01. The phages are allowed to amplify for 6 hours or until the culture clears in a shaking incubator at 37 at 200 RPM. Phage lysates are then filtered through a 0.22 micron filter, a PEM membrane, to remove viable cells. These filtered lysates are then concentrated using 100 kilodalton cutoff centrifuge concentrators until the entire lysate is reduced in volume. And the titers are determined using the standard double auger layer method. And then endotoxin concentration is then determined through a limulus amoebocyte lysate assay, or LAL assay. And then once that is completed, the phages are diluted in phosphate buffered saline supplemented with magnesium sulfate to a concentration of 1 times 10 to the 10 plaque-forming units per dose. And they're tested for sterility per USP 71 guideline, and also for exotoxin A using an in-house Western blot at Yale, which is sensitive down to less than 1 picogram per mil. Just a word about Pseudomonas aeruginosa 27853, just because in a separate case I'm involved in for another patient receiving phage therapy, this came up, and I guess reviewers wanted to know about the strain in which the phage was being amplified upon. It makes sense, I think, from the rationale that possibly generalized transduction could occur during amplification of the phage on virulent strains. And so the strain was isolated from essentially the Brigham and Wilson Hospital in 1971 from a blood specimen. It's an MLST 155 typical model strain to assess antibiotic susceptibilities. And just a bit about the genome of the strain. It was closed in 2017 by Cow. It's a 6.8 megabase contig with 158 X coverage. There's about 6,300 genes within the genome. The genome harbors 7 prophages and 25 genomic islands. 4 are prophage associated. The strain has been shown to increased hydrophobicity, enabling biofilm formation on polystyrene. It was shown to have that phenotype due to a lack of a B-band O antigen and increased expression of the type 4 pilus and flagella genes versus PA01. It has a non-mucoid morphology due to low alginate production, and it has enhanced piocyanin production, which was shown recently to bind extracellular DNA, enabling matrix development within Pseudomonas biofilms. And this is just some pretty pictures to go along with what I just said. So 27853 is shown in the top panel in the dark square symbols, and then PO1, and this is showing piocyanin production in LB broth over time. This is over a matter of 3 days. And then this shows the difference in biofilm formation between 27853 and PA01 in the presence of Congo red. That's why these look red and not your typical blue-green we used to see with Pseudomonas. But you can definitely see there's a difference in morphology there. So this is what we found in our phage products. They were endotoxin concentration that was determined and found to be acceptable per FDA endotoxin limits, so 5 EU per mil per kg in all of our different cocktails that we were going to use. They also passed USP 71 sterility testing and had an undetectable exotoxin A level. Let's see. So we did allude earlier to some issues that we had during the treatment of our patient. So when the product was initially shipped on November 17 from Yale and shipped with ice packs and styrofoam packaging in a multi-dose vial, it was 50 ml Falcon tube. At our hospital, there was condensation appreciating outside of the vials, and the package temp was judged to be at room temperature when it arrived. And the volume that was in the vial was actually different from what was anticipated. And so for that reason, the phages were actually refused by the CU pharmacy for administration to our patient. And this held up phage therapy for about a month and a half. So new phages had to be sent to Lady to start till, this should actually say January 4th. That's a typo. So this was, when we bring these up, not to point fingers, but just to let people know for their home institutions, if people haven't done this before, what our pharmacy was looking for. And so this is what our pharmacy was looking for. Our phage prep needs to be sterilized and placed into a sterile single-use glass container for drug preparation on the day of the clinic visit. The drug must not be supplied in the multi-dose container. Each sterile batch of drug must be accompanied with a sterility report as well as an endotoxin report, which is kind of redundant because we had already supplied this to the FDA, but it always helps if people have the paperwork so that we can be on the same page and be comfortable with what we're doing. Each vial must be clearly labeled with its contents and the investigational drug caution statement, date of manufacture, date of expiration at a minimum. And the drug must be shipped at the recommended storage temperature. And then documentation of the stability of the drug and the recommended dilutants were kind of their factors that our investigational pharmacy was focusing on. Long story short, there was other bumps in the road. So in between getting more phage to treat the patient, in January, she developed C. difficile associated diarrhea. At that point, she had been on approximately 4 months of IV antibiotic therapy. The patient was started on oral vancomycin treatment dose, which is 125 milligrams every 6 hours for 10 days. This was her first episode. So phages, as Laura mentioned earlier, if it had to be infused in the infectious disease clinic Monday through Friday, we have a private company that does our outpatient antimicrobial therapy, but they couldn't participate within this investigational new drug administration. And it was kind of hospital policy that we had to perform the infusions at the infectious disease clinic. And this is essentially what was done by others, Cano et al. At Mayo Clinic, when they were treating a chronic Klebsiella pneumonia prosthetic joint infection. And so here's kind of our schema here of how we treated our patients with bacteriophage. So you can see throughout this entire time, the patient was on cefepime 2 grams IV Q12 hours. And at this point, she was on suppressive dosing of oral vancomycin for C. diff. We started on January 4th to January 17th with phage INF. It was just a single phage in this first therapy. During this first week, there's some interesting, one in particular interesting development. On day 3, the patient developed blue-green urine, and we weren't able to recover any bacteria, but we took this to represent Pseudomonas, given this is the prototypical color of the bacteria, and wondered if this was being liberalized off the patient's suprapubic catheter. Now, in the first 2 weeks, she also developed a pressure sore on her right heel that kind of complicated the interpretation of her inflammatory markers later on. In the second 2 weeks, she developed dyspepsia, gastric upset, also some diarrhea. We're really sure what it caused this. The patient had a past history of collagenous or microscopic colitis, but she wasn't on budesonide, as we had mentioned previously. We were curious whether magnesium could have caused this event. Usually magnesium has to be taken orally, the way I understand it, to cause diarrhea. This was being infused in her IV, in her suprapubic catheter, into her spinal drain. She wasn't really taking it orally, but we held the magnesium anyways. We never really got a good handle as to what was causing her diarrhea, although we were able to get it resolved. Wondered if there may have been some dietary factors that may have promoted this as well, but we were able to control and continue on with phage therapy. Throughout the rest of her course, the patient tolerated all of the phages that she was administered quite well. The only thing she really noted was that she had a lot of fatigue after receiving phage, which seemed to go away on the weekends for what it's worth. Outside of generalized fatigue, there wasn't much else that could be considered an adverse event. And so the patient did get her CT spine on the 4th week of treatment. And you can see here her CT spine from September of 2020. We showed you previously there's these gas pockets within the thoracic spine and then a little one further down. And you can see those are now gone in the February 5th CT spine that she had. What you can see, pointer's not working, apologize, but over to the right side of her panel, just beside her spinous processes, is the drain. Further down, you can see her fusion here as well. But the bones look intact, as well as the hardware. There's no signs of infection per our radiologist. And so we took this as a reassuring sign. Maybe her infection was getting better. This is a look at her, some of her cell line values. So what I'm showing you here is her white blood cell and absolute neutrophil count on the left-sided y-axis, and then her platelet count on the right-sided y-axis. And November 20th, 2020 represents when the patient was diagnosed with C. diff the first time. And that's why her platelet count is so high here. We mentioned she starts phage therapy kind of where this line indicates right here. And there is some wavering of the platelet count during the course of phage therapy here. Of course, she had other medical issues going on at this time, her foot, and also some diarrhea. It wasn't until after she had finished phage therapy that there was an increase in her white blood cell count, her ANC, her platelets, and that coincided with the recurrence of C. difficile on March 16th. I'm showing you with this arrow right here. We monitored her CRP during this time as well. And for the most part, her CRP was actually increasing, which would be alarming, but not in the sense that she also had other confounding issues. And so this is just a generalized inflammatory marker, and you have to take it for what it's worth in the context of your patient. And so even though our CRP, this inflammatory marker, was increasing in the presence of phage therapy and antibiotics, we think this was most likely related to her foot. It normalizes here after, or the day she finishes phage therapy, and then skyrockets again here whenever C. diff recurs. So what was the aftermath of this first phage therapy experience for this patient? So we were unable to recover Pseudomonas aeruginosa from the suprapubic catheter. We sent several suprapubic catheters that were removed by urology for sonication and culture. We were never able to recover Pseudomonas in any of these specimens. And this is similar to the experience that Ben Chan had in treatment of his patient with an infected aortic graft, if you review that case report. The patient, as I already mentioned, had recurrent C. difficile associated diarrhea. Though on a bright note, we weren't able to recover Pseudomonas. She had now been colonized or infected with a new bacteria. So she had an ESBL, so extended spectrum beta-lactamase E. coli that was also quinolone resistant. In late March, she returned to for another infectious disease office visit where urine was cultured again. I believe she was symptomatic at this point, but she'd been colonized with another bacteria, Klebsiella oxytosa. So you can see she's still having issues with colonization of her suprapubic catheter, and that's the downside of having a piece of plastic within your bladder. But it's reassuring that we're not seeing Pseudomonas in her urine, suggesting that it may be gone after 8 weeks of phage therapy plus cefepime. On April 9th, she had to be brought in by ambulance for altered mentation. She was admitted from the 9th to the 12th with E. coli bacteremia and urinary tract infection. 28th of April, about 2 weeks ago, 2 to 3 weeks ago, she had suprapubic catheter incontinence, which one of the providers thought may have been related to infection. A urine culture was checked, and she had greater than 100,000 coliform units of E. coli within her urine. At that point, she was prescribed trimethoprim sulfamethoxazole. For someone who is still trying to recover from C. diff, you can imagine this is not maybe the greatest possibility that could happen for her. And as you'd imagine, she was readmitted from April 30th to May 7th with new diarrhea, recurrent C. difficile diarrhea, and she was put on a fidaxomicin taper. It's really unclear if she really had a bladder infection, urinary tract infection. So some conclusions from this case. There haven't been any recurrences of Pseudomonas aeruginosa infection, either in the hardware or in her suprapubic catheter, from what we can tell. It's always been other bugs. So at least at the 60-day point post-phage therapy, we think we have eradication of the infection. This is the first report to our knowledge of treating vertebral osteomyelitis with hardware, with phage therapy and antibiotics. Maybe it'll serve as a way forward for treatment of other hardware-related infections, either in the spine or elsewhere, we think. Some questions that we have after this case: did she really require 8 weeks of phage therapy? We're not sure, but essentially that's the standard of care that we had in our mind. And just taking a conservative approach in the absence of data. We wondered, would intravenous administration of phage be sufficient? Did she have to have phage put into her spinal drain? Did she have to have them put into her suprapubic catheter? We don't have good answers for that yet. Was there phage antibiotic synergy? We're currently assessing for that right now. I wonder if there might have been a synergy between cefepime and the phages that were used in this patient. And did the phage promote the diarrhea and the fatigue that she experienced? Not really clear either, although we couldn't really find much literature on this topic, and there was other reasons why the patient could have had these issues as well. So limitations: we cannot prove that that antibiotics alone may have cured her hardware infection. But we think that it's likely Pseudomonas was still there, given the blue-green urine that we saw on her suprapubic catheter on day 3, and her really slow response to antibiotic therapy alone earlier in her treatment course. So we still think that Pseudomonas was there on the catheter and hardware. All right, so we just want to thank some people, our collaborators at Yale, especially Ben, John, and Paul Turner. I want to thank our clinical microbiology lab for helping us send off specimens. It's Nancy Madinger and Bruce McAllister at University of Colorado. Thank our pharmacists, Lene, Prashant, Matt, and Kyle. Dr. Kleck and Seaver with orthopedics. Our infectious disease nurses, Anne Marie and Rich, who were with the patient Monday through Friday through 8 weeks. And we're actually on the front lines of this case and a big help to us. So we really thank them a lot. Plastic surgery, Dr. Mason, thank our folks, College of Medicine, IRB, Heike and Lori for helping us through this process. We thank our colleagues at the FDA, Kara Fior, Marion Gruber, Laura Galchuk, for assisting us for our first time in the IND process for phage therapy. It was really smooth and we had a great experience, we thought. Other investigators that we spoke to during this first time experience, Gina Sue at Mayo Clinic, and then Dwayne Roach at San Diego State and IPATH. And then we want to thank Jessica for giving us the opportunity to speak to y'all today, and just our families, and we'll take any questions y'all have.
Thank you so much. Awesome. That was so juicy and rich with information across the clinical side and the phage side. We've got some questions coming in about, I'm seeing a lot about the biofilm work. So we'll do some questions and then hopefully we'll have time for one breakout room. Might go a little past the top of the hour, but people are of course welcome to leave whenever they have to. So I'll start with a question from Scott Stibbets. So you're looking at inhibiting biofilm formation in the presence of phage. Do you have any data on sensitivity of already formed biofilms?
Yeah, we didn't have any data like what Ben had from his prior paper with phage OMKL1 inhibiting biofilm formation on Dacron grafts. It was basically just hoping and praying, I guess, that this would inhibit biofilm formation on the surface of the metal in her spine and also on the suprapubic catheter. But the blue-green urine that we saw on day 3, I mean, I've treated with a lot of antibiotics. I've never seen antibiotics do that. So I thought that was kind of interesting when her urine turned blue-green. So I don't know if that was bacteria being liberalized off the biofilm that was on her suprapubic catheter or what that represented. So
yeah, it's crazy. It's cool. All right. Then Krupa Parmar asks the induction. The induction of prophages present in Pseudomonas may get triggered by low concentrations of antibiotics. Did you test this?
No, that's a good point. Yeah, that's right. They get an SOS response and be induced. I guess, phage infection I wonder if that would induce an SOS response too. That's another type of stress. We just, we don't have much insight as to what's going on with an SOS response, but.
Got it. Yeah. And that was another question you kind of touched on. Scott had that question too, if they could be triggered by superinfection with the therapeutic phages that you're adding, these prophages. So.
Yeah, I think that was a concern that, folks have had, in a separate phage therapy case, could antibiotic resistance genes get packed within the head of the phage, and could this get passed along to a patient through a generalized transduction mechanism? I think that's possible, but I don't know how effective that is in the clinical setting. So yeah.
Awesome. How do you make sure the phage 45 and phage BOI is sensitive to the biofilm or biofilm sensitive to the phage after the phage INF treatment? You can't use the original bacteria to test it because the receptor will change after the phage INF treatment.
Yeah, I think this was done mostly in vitro work. So yeah, they would, it's just a prediction off in vitro work. Yeah, because you're right. If you're not able to recover your bacteria, you're probably pretty much shooting in the dark, and you're just going off the predictions made in the lab. And it could be that maybe after a phage INF treatment, after 2 weeks, maybe the patient had cleared at that point and we were done. You can't really say though.
And I would just add too that it's hard because with spine infections, we really can't get repeat cultures. And that's what everyone kept being like, oh, well, can you send us repeat cultures? And to go get deep bone biopsies every couple of weeks really is there's too much of a risk there in this case. And it isn't really easy access with that much metal. So we kind of just had to go with this phage cycling approach that the people at Yale recommended. But yeah, we didn't have a way to know for sure.
Got it. From David Saez, hello, great talk. Very interesting to see how the whole process went. I have a question for Greg. I'm curious about the phage production. Since you mentioned the strain used for propagation harbors 7 prophages, did you check if those prophages are excised and present in the phage lysate before administration, or do you see this as a problem? Thanks.
Yeah, it could be a problem. Yeah, I mean, absolutely. 7 prophages. Yeah, you'd like to use maybe a prophageless strain to amplify the bacterion, or the amplify the phageon, excuse me. Um, but it makes you wonder, like, is it really a problem, or are we just, how frequent are these events? And you look at my knowledge is in the enterococcal literature, and when you look for generalized transduction of aminoglycoside resistance between phages and enterococcus, it's on the order of 10 to the -7, 10 to the -8. I guess you'd have to have a high burden of infection there to have one event happen. So it makes you wonder, is the event frequent enough in a patient where it would make a difference at the end? It's possible, and maybe it's more likely the longer you treat a patient with phage therapy.
Got it. Awesome. Okay, 2 more questions I think we'll get to. So Newton Fernand asks, or he says, insightful presentation so far. I could clearly figure out the importance of basic science, scientific data, and the implementation of compassionate use phage therapy. Great job. However, what was the buffer that you used to dilute your phages upon administration to the patient?
I think it was just phosphate buffered saline with magnesium sulfate. Yeah,
That's correct.
Yeah.
Yeah, it was just saline.
Mhm.
Awesome. And Gina says, this is a great case. Thank you for sharing. I think duration of therapy is definitely a factor, and 8 weeks seems very reasonable. But was there any concern at any time about leaving the spinal catheter in place for that time period?
So yeah, there was definitely concern. It didn't go intrathecal. It went down through these like draining sinus tracts, kind of right up to about the hardware. And there was a lot of concern, especially from the plastics department, that we were going to destroy their flap and we were going to be infusing volume of fluid in. And we were like, look, we're only talking 5 cc's of fluid a day. And we'll make sure that, we try to aspirate before we put new stuff in the next day, because it should be getting absorbed. There was a lot of concern from the spine team, but I think in this case, we just had so many limited other options that made an opportunity to give this a try. The 8 weeks, and Gina, we got that from you because that was one of the things that you recommended was the longer duration. I've got another guy that I submitted to the FDA Friday, and I know that they've at least received it, but he has vertebral osteo with a almost XDR Klebsiella, and we're contemplating treating him with just, I think, a 4-week course. I can't remember if I recommended 3 or 4 weeks, but we're thinking shorter. And so we were going to see if we get different outcomes with that too.
Very cool. Oh man, the questions are flowing now. So Gina says, was the catheter exchanged out at all, or was the same one kept in place?
Yeah, I believe
I'm trying to remember now.
Yeah, I'm pretty sure it was exchanged, I thought, at some point.
We exchanged it and sent it to Yale to be sonicated, and we couldn't get anything off of it, at least once. I think it was exchanged monthly, to be honest, at one point. The patient's on the call. I don't know if she wants to add, because she probably remembers how often she had to go in for that. But, and the fenestrated, it's whatever they would usually put in an IR for like draining a wound. I just asked them to put a drain in. I think it was just the one opening at the end. And then interesting, Gina, you had success with 6 weeks and failures with shorter courses. Yeah. I don't know. This next guy, what's interesting is he's a case where he's non-op at this point, and he's only 50 something years old. And so he's one where we're going to treat him for a couple of weeks and then do an IV antibiotic holiday and then actually repeat a bone biopsy. So in his case, we'll be able to prove whether or not we make progress and do we return sensitivity to some of these antibiotics, because he's on Vabomere right now and failing therapy. So his will be an interesting one I'll keep you guys up to date on that.
Incredible. Yes. Thank you so much, both of you, Greg and Laura, for sharing your story, your case today. We're at the top of our hour. So just before everybody heads out, I want to quickly share a slide to talk about the next PHAVES event that we're going to have next week. So let me just share that. We are going to have Quentin Lamy-Besnier from the de Barbier lab at Institut Paris. Yeah. Institut Pasteur in Paris. That is next Tuesday. So it'll be different time slot, take note. But this is on the phage research side of, so more in line with our standard faves series, but he's gonna go through this new database that they made, viral host range database. So for anyone who wants to learn how to use it, he's gonna actually walk through the online tool that they made for recording and analyzing virus host interaction data. So I just wanna make sure everybody put that on their calendar. We're gonna be sending out an email after this talk, so come to that one. And yeah, so yeah, keep us posted, Greg and Laura, on your next patient, and maybe you can give another talk on that one. And yeah, everyone else, thanks for coming. If you would like to stay for a breakout room, please stay and I'll randomize us. Just a 5-minute kind of meet and greet, meet somebody new. Otherwise, feel free to go on with your day, and we're gonna post the recording on YouTube on our Phage directory channel, so you can find it there. But any last remarks, Greg, Laura, or anything I didn't say?
No, I just want to say thanks to everybody for letting us be a part of this. And if you have any questions, you can feel free to email me. I'll put it in the chat. But if you have questions, comments, I'm open to anything. I'm very new to this work and excited to be a part of it.
Yay. Thank you so much. Yeah. And I always share the chat with our speakers. So if anybody wants to, shout out to Greg, Laura, you can throw it in the chat right here in Zoom, and I'll share that with them, or happy comments or anything like that. So, or more questions, I'm sure. Okay, so with that, if you're gonna leave, go ahead and leave. If you're gonna stay for breakout, I'm gonna start randomizing us, and you can stick around. And I'm also gonna stop the recording now.